speaker this evening is Dr. Georges Debled. Dr. Debled is well known in medical circles for his vital and original work in the field of urology. He is the author of many papers which have earned him great respect and recognition by all in this field. His recent book on the male menopause, the andropause, shortly to be translated into English, is regarded as the definitive work on the subject. Dr. Debled spent much of his clinical life in Brussels, but for the past 5 years has lived and worked in Paris, where his special interest is in the medical and surgical treatment of the female and male climacteric. I want you now to share with me my pleasure at meeting him, Dr. Georges Debled.
Thank you, Mrs. President, dear Patricia Puglio. I thank you so much for your invitation, and I bring you un grand bonjour de Paris. Now, ladies and gentlemen, good evening, and be careful. I will speak English. Now, what about the male climacteric? You heard something about those women, but men are also concerned. The influence of male hormones upon the human body has been known for numerous centuries. Aristotle described the special fatty appearance of eunuchs. The Greeks, at the time of Jesus Christ, believed in the existence of a special substance responsible for long life. With animals, the effects of the lack of male hormone have also been known for a long time. The capon doesn't develop its sexual characteristic and its crest remains rudimentary. Slide on, please. Put the light on, please. Okay, thank you. You see here, this is a chicken which is castrated and doesn't develop its crest. When you give male hormone to this chicken, it develops his crest, which is a sexual organ. For 40 years, in 1849, Berthold demonstrated that the capon's crest recovers all its characteristics when the testicles are implanted in another part of the body. This experience proved that the testicles secrete a substance which acts at distance on the voice, the plumage, and the crest. The first description of the male climacteric was made by August Werner in 1939 in the Journal of the American Medical Association. And he wrote, "It seems reasonable to believe that many, if not all men, pass through a climacteric period somewhat similar to that of women, usually in a less severe form, but perhaps a more prolonged form." And he stressed the good results obtained with intramuscular injection of testosterone propionate in 2 patients. In 1974, because there were so many men seeking help for sexual troubles in my urological department, I decided to create a new department exclusively for andrological diseases. At this time, it was possible to analyze the levels of male hormone in the blood with the precision of the picogram. I immediately remarked that young men with normal and abnormal testicles showed similar problems and similar hormonal results. Those problems were not psychological, as demonstrated by hormonal analysis. At the same time, I was impressed by similar hormonal results from young and old men presenting similar problems due to a lack of male hormones. Those problems generally responded well to androgen therapy. No, next slide please. This is to show the decrease of male hormone. This is the mean value decreasing with age, and those hormone peaks at 35 years. Next slide, please. But testosterone must be free to be active. And you see that with age, free testosterone decreases more dramatically. Next slide, please. In the urine, you have also a decrease of testosterone secretion with age, and you see it peaks also around 25, 35 years. Next slide, please. Now, what are the consequences of the decrease of male hormone? First, you have the sexual symptoms, and one of the greatest is the incidence of impotence in men. You see, after Kinsey, that with age, the percentage of impotency increase. At 60 years, you have 18% of impotency, that it increased certainly after. Next slide, please. After other authors, Perlman and Kobashi, you see also that around 40 years, you have 5% of impotent men. Around 60, you have 35%, which is not nothing. And after, it becomes dramatic. Next slide, please. This is to show you the influence of male hormone on the seminal vesicles. Those are seminal vesicles of a castrate rat, and when you give those rats testosterone, you have an increase of the seminal vesicles. It means that the secondary problem with andropaused men is a lack of ejaculation. And you can understand that very well through this picture. Next slide, please. You have also a lack of libido. And this is well checked. You have here, around 20 years, only 88 men having more than one sexual intercourse per week. Around 60, only 50% of men have more than one sexual intercourse per week. The normal would be 2 or 3 times a week. So, the 3 main problems are impotency, problems with ejaculation, and also premature ejaculation, and lack of libido. At the same time, the sexual organs will be involved, and you have also problems with the prostate which is the sexual organ. The definition given in the French literature by the dictionary and also by Rouvière in his treatise of anatomy lead to the popular concept that the prostate is a glandular mass surrounding the initial portion of the urethra. This is incorrect because this definition gives a wrong conception of the prostate, which is believed to be only a glandular tissue. In reality, the prostate is a fibromuscular mass in which some glands are more or less developed. Those structures are situated between the bladder neck and the sphincter. And the role of this muscular tissue is to open, to participate to the opening of the posterior urethra. This fibromuscular muscle is sensitive to hormone. And when you have a lack of male hormone, the fibromuscular mass of the prostate become fibrous and sclerotic and rigid. Next slide, please. This is to show the fibromuscular mass in which you have glands. Next slide, please. When you have a lack of testosterone, this muscular tissue is involved and transformed in fibrous tissue. It's very important because it's an obstacle. Next slide, please. This is the endoscopic view of a prostate which is fibrous. Before the operation, the opening of the bladder neck is very small. Next slide, please. You see the difference after the operation. Here is the opening of the bladder neck. And next slide, please. You see at the pathologic specimen that it is completely fibrous without prostatic glands. So the decrease of male hormone makes always a transformation of the prostate tissue in a fibrous tissue. This is for the muscular part of this organ. But at the same time, you can have a transformation of the prostatic glands. And the metabolism of androgen in elderly men with benign hyperplasia is often altered, and you can find in studies in the literature that you have an imbalance between male hormone, and in benign hyperplasia of the prostate you have often an increase of female hormone in men, which is very important and which makes the lower level of testosterone worse because of the imbalance. And when you do a treatment for the male climacteric, when you have low levels of testosterone and when you balance well those sexual hormones, you see very often an improvement or a disappearance of the urinary symptoms. And this is also true for prostate atrophy. So the surgical operation can sometimes be postponed for 10 years or more. And I am a surgeon, it's me who is speaking, you understand. Now about prostate cancer. Today, the cause of prostate cancer is not known. The clinical form of this cancer arises generally around 70 years, when sexual hormonal levels are very low. The use of testosterone to regulate hormonal imbalance is a means, I think, of prevention of prostate cancer and perhaps for other cancer. Why? Because testosterone stimulates immunity. There are a lot of reports which prove that. And now we have an epidemiological study which was reported in 1988 by Abraham Nomura and his colleague from the University of California in Los Angeles. And this report points out a relationship between sex hormone and the prostate risk. Serum samples were obtained from 6,860 men between 1971 and 1975. After a surveillance period of about 14 years, 98 cases of prostate cancer were identified. Their sera, their stored sera, and that of 98 matched controls from the study population were tested for the following: testosterone, dihydrotestosterone, estrone, estradiol, and sex hormone globulin. There was a suggestion that serum dihydrotestosterone levels were lower and the testosterone dihydrotestosterone ratios were higher in the prostate cancer cases compared with their controls. So there seems to be something there, but we need more information. But this is the first time that an epidemiological study proves a link between sexual hormones, a lack of sexual hormones or an imbalance, and prostatic cancer. We have also a study from the Birmingham University which demonstrates that slice of human prostatic adenocarcinoma cultured in the presence of testosterone showed a morphological change to a more differentiated type of neoplasm. This is fascinating. And in my more than 15-year experience, because I give androgen therapy since more than 15 years, I never saw the development of an invasive prostatic cancer under continuous androgen therapy. So next slide, please. This is to show the mean values of testosterone in plasma. Between 20 and 30 years, you have 1,000 to 700 nanograms for over 100 milliliters. Between 30 and 60 years, 700 to 60, and around for 140 to 40, around 80 years. So, when you see a result of 400 in your patient, there must be patients around for 80 years. But you will see those results in men, because in men of 60, of 30, and even in men of 20 years. Next slide, please. So, because the decrease of the hormonal levels with age, the idea is to restore the level of a young man who is in good health. And it's why I call this the ideal hormonal outline. The value of LH are between 2 and 5, FSH 2 and 5. Total testosterone, ideal testosterone, between 700 and 1000. Here are the units. But this testosterone must be free, and the normal levels are between 140 and 200 picogram milliliter. Dihydrotestosterone must be around 100 nanogram per over 100 milliliters. Estradiol not more than 20. And this is the sex-binding globulin, 3 milligram per liter. But this is ideal at any age. Next slide, please. So if you found, this is an example, but there are a lot of examples. LH is too high, FSH too high, testosterone very low, dihydrotestosterone 2, estradiol 2, and this is an example of primary testicular insufficiency at any adult age. It's an excessive result, but it's only to give an example. So, as treatment, we give, there are 3 methods for giving androgens: intramuscular injection, gel, testosterone gel you can put on the skin, and pills. And each patient, I say it always, is unique, so you must find the good levels of hormones. Each patient is unique, and each doctor is unique. And it's with experience that you will find your way in this hormonal therapy. But there are great rules. It's not the place here to give the details. If you want, I can give you after. Are there contraindications to the therapy? Yes. The first contraindication of androgen therapy is the lack of indication, but it must be said. In theory, androgen therapy is contraindicated in theory. In theory. It's because I am prudent. In theory, androgenotherapy is contraindicated in cases of aggressivity, prostate cancer, or severe failure of cardiac, renal, and hepatic function, but those are poor conditions beyond any curative medical therapy, and which are generally lethal. So androgenotherapy is, because it's a preventive treatment, has no many contraindications normally. And today, comparing the hormonal results of more than 1,500 patients, I may conclude that after 40, every man will be affected at one time or another by the male climacteric. This degenerative phenomenon is the cause of sexual involution, and last but not least of aging. All patients were treated without interruption, sometimes for 15 years, with appropriated levels of androgens, with highly impressive results and without complication or danger. And now we must see the general effect of the lack of androgen on aging. Androgens are everywhere in your body. They are receptors of androgen in the hair follicle, in the testes, in the uterus, and in reality, small quantities of androgen receptor have been observed in numerous organs. You know that it is effective for the protein metabolism. You know the effect on bodybuilders taking all those synthetic androgen. This is the error of the bodybuilders because they take synthetic androgen which are very bad and which have side effects. What is not really known by the clinician is the influence of androgen, of testosterone, on the sugar metabolism. And this must be known because it's very important. Next slide, please, if you... Yes, this is only to show the first book on the male climacteric, which was published 3 years ago in French, and we hope that the Barnes Foundation will help us to translate it in English. And this book it concerns mainly the sexual involution in men. Next slide, please. So, you must know that testosterone puts the sugar in the muscular cells. So, it is hypoglycemic drug of hormone. When you have a decrease of testosterone with age, you have hyperglycemia, which gives an intense reaction of insulin. As a consequence, you have an hyperglycemia, an excessive food intake, and again hyperglycemia, aggravated by the decrease of testosterone. So, the decrease of testosterone leads to diabetes. Next slide, please. And this is proven by sugar tolerance tests by several authors. The first one who spoke over that, it was in 1947. It was Professor Giuseppe Pellegrini in Italy, who wrote a report entitled L'azione antidiabetica degli ormonali sessuali maschili nel quadro della fisiologia del diabete. So that means lack of testosterone produces diabetes. So the tolerance curves of glucose before treatment with testosterone. After treatment of testosterone, you have an improve of the glycemia after the tolerance test. And it improves more with the time. So when a diabetic patient is treated during 2 or 3 months with male hormone, you improve his diabetes anyway. And the sugar levels in the blood are decreased from more than 1 gram. So what is interesting to hold in mind is that testosterone has an anti-diabetic effect, but with a long-lasting action. Next slide, please. This vicious cycle of glucose lead to an accumulation of cholesterol and lipids. This is mathematical because you have again this vicious cycle of testosterone, so the decrease lead to hyperglycemia, then you eat too much, but the catabolism of the sugar doesn't work very good, and you have anyway an accumulation of cholesterol and lipids which are coming from a too great sugar food intake, but also from an imbalance with your male hormone. And it is a reason because it's so difficult to hold a regime when you are overweight, because you have the imbalance. So you need always this sugar, and you You eat too much because you feel better, because sugar is good or alcohol is good, but then you accumulate lipids and cholesterol. Next slide, please. So, those troubles, this accumulation of fat, you find that in the studies of the normal values for triglycerides in the American men, so it is true, huh? And you find those results in the lipid research program of the NEA, the National Institute for Health. What do you see with age? With age you see in the whole of the population an increase of triglycerides in the blood. At 20 you have 89 milligram percent, but you have twice this rate, around 50 on the whole population. And you can ask yourself from where it comes. It's a whole population. But in the whole population you have a decrease of male hormone. So I think it's a connection between the two. Next slide, please. Same for cholesterol. Here is also a program research of the National Institute for Health. You see what we call the bad cholesterol, 100 around 20 years, at an increase to 142 around 50. On the whole population, how is that possible? Because the whole population is becoming older and have a decrease of male hormone. Next slide, please. And so, accumulating fat, having sugar disease, you have overweight. And this is very important because you see the rate of mortality when you are overweight. It increases dramatically with the percentage of overweight, twice here. When you overweight in percent is 50% higher. Next slide, please. And you see here, it's also an experience of the Metropolitan Life Insurance Company. If you see the causes of that rate for overweight, you see the link here with the diabetes, always the sugar, and the sugar is linked with male hormones. Next slide, please. So you need, if you want to do something, you can calculate your body mass index, which is your weight in kilos divided by your age in meters. It should be 22. If your body mass index is higher, over 27, you have the risk of cardiovascular disease 3 times more. If you are over 30, 7 times the cardiovascular risk. And if you have more, we don't know. Next slide, please. And this is to prove. There are several reports on this subject that in the obese group of massively obese men, you have a low level of testosterone. If you have a control group, you see again the 100 nanogram for 100 milliliters. What we also know by the studies of Zumov from the Division of Endocrinology and Metabolism from the Beth Israel Medical Center in New York, they proved that there is a link between overweight and male hormone decrease. Even if you are overweight from 1 or 2 kilo, it's overweight, and there is a link. It's a continuous link between male hormone decrease and overweight. Another influence of the lack of male hormone is muscle weakness, because the metabolism of the muscle is influenced by testosterone, which increase the quantity of specific contractile proteins as seen with bodybuilders. But testosterone increase also the input of glycogen into the muscle cells. And glycogen, coming from the sugar, we have seen it, constitutes fuel and energy for the muscle contraction. And this is proved by athletes which are consuming a large amount of testosterone during exercise. And so when you are an andropause man, you have not too much male hormone, and you want to prove that you are a man, a big man, a leader, even a president, why not? And you do jogging, and more jogging, and more jogging, and the more you do jogging, the more you decrease your testosterone. And have on a day, you have a tachycardia, and then you can have a confusion with hypothyroidism. But it is not necessarily true. When an andropause man makes too much exercise, he is consuming his sugar and his energy, and the heart, which is not the heart of Jesus Christ, or of a lovely heart, of sweet heart, the heart is a muscle. It's a muscle, only a muscle, and it needs energy. So when you do exercise, you are consuming male hormone, and it's very dangerous to do excessive exercise without taking male hormone. It's why also with the Olympic Games, a man of 40 can win the Olympic Games because he is deprived in male hormone, and only young athletes can win the Olympic Games. Next slide, please. This is also interesting. It's the average variation of blood pressure in the blood with age. And its observation was made upon 250,000 healthy Americans. And you see at the age of 20 that the systolic pressure is 120/80. When you are 60, you have 135/89. So it's an increase. And you can ask yourself, because it's upon 25,000 healthy American men, why is this pressure growing up? Well, arteries are made by muscles, and those muscles need testosterone to be contracted. And with the decrease of male hormone, you have a weakness also from the muscles of the arteries. And then those muscles are replaced by fibrous tissue. And this is the reason because for what the arteries become stiff, because muscles are replaced by fibrous tissue. This is one reason. And the other one is that because you have the vicious cycle of sugar and cholesterol, you have atherosclerosis, is to say, fat in the wall of the arteries. You have the same problem in the veins. The varicose veins are very common in andropause men, but it is also a weakness of the muscles of the veins, and same problem for hemorrhoids. Now, next slide please. There are a lot of reports showing that you have a correlation of the coronary heart disease with the cholesterol, you know that, but a negative correlation with the good cholesterol, HDL cholesterol. Next slide please. And the metabolism of this cholesterol is correlated with the sexual hormones by several reports. There are many, many reports on that. So when total testosterone is low, you have a positive correlation with coronary heart disease. The same for the free testosterone, when it's low, positive correlation. Again, with dihydrotestosterone, positive correlation, and estradiol elevated, again, a correlation with coronary heart disease. And you find that in elderly men. Next slide, please. This is pictures taken from the Möller's work. It's only to show the influence on testosterone and its gangrene. Next slide, please. At the beginning, he gives testosterone. A few weeks after, it's better. Next slide, please. 1 month after, next slide, please. And 3 months after, you have a healing. So testosterone has a big power to build the body. Next slide, please. Here is a big ulcer of the feet. Next slide, please. After several months of treatment, it's completely healed. Next slide, please. This is terrific. It's a gangrene of the feet, which should need cutting of the leg. Next slide, please. After treatment of testosterone, you see the healing. Next slide, please. And this is after 3 years of treatment. It's completely healed, but this man has his legs, and so he can walk with his own legs, but this is the result of the treatment with testosterone. So what is proved also with cardiovascular disease is that for myocardial infarct, you have also a correlation, it's proved. You have in the United States each year 1,500,000 persons who are attacked by myocardial infarction. And the immediate mortality is 35%. In 15% to 20% on the patient die during the first year following the heart attack. There are several reports which prove that when you have a myocardial infarct, the level of testosterone are very low. You have a report of Jaffe in the British Heart Journal which proved the testosterone, the effect of testosterone on the heart muscles by double-blind study. He put patients with treatment and other improved that the testosterone improved the contractility of the heart. So another effect of the lack of testosterone is stiffness, limitation of the movement, and arthrosis. Collagen tissue is made by collagen fibers which are bound by bridges, and the natural composition of collagen makes its elasticity. What you must know is the reaction of Maillard is the fixation of glucose on everything, even in conserve. So sugar goes on everything, is fixed by every protein. And in collagen tissue, the glucose, sugar, goes into the bridges and make them stiffer. So we can say that the loss of male hormone, we have seen that it leads to hyperglycemia. And it is why the sweetened middle-aged men become stiff, but not at the right place. So what is it also proved is osteoporosis proved by report as for women. So when you have a lack of testosterone, you can break your bones. Huh? Next slide, please. So you have a transformation of the silhouette. This is a man of 20, 25, 30, 35, 45, 55. It's very common. Look around you. Next slide, please. Another effect of testosterone decrease is the kidney insufficiency by 3 ways. First, you have a lack of influence of testosterone on the tissue, the renal tissue. It's necessary for eutrophy. Then you have arteriosclerosis also, because we have seen that, of the renal artery. And then you have this particular phenomenon, which is not well known. And I come again with this fibromuscular mass, the prostate, which is not a gland. Next slide, please. You must understand that during voiding, the bladder neck and the posterior urethra must open. And it is not because you have not a big obstruction, a stone or a tumor, that it works good. So when the mechanism is stiff, the opening works not very well. And next slide, please. This is, you know that this is an obstruction, and you know then that you can have kidney insufficiency. Next slide, please. But this mechanism, you don't know that, because it's particular. When you have not the opening, you have a reaction of the terminal ureter, which stretch immediately, and which the obstruction is here, and is the consequence of this, and you make then ureterohydronephrosis. It's very common, but here it's hydronephrosis. It begins by a small dilation of the urethra, and it's not well diagnosed. But you can do the diagnosis when you have the ureum rate above the normal, around 40 milligrams, 50 milligrams over 100 milliliters. You must be careful for this, because you are very tired when your kidneys doesn't work well. So you can have also problems of vision and auditory problems. Why? Because the small bones of the ear and their ligaments, the connective tissue of the eye, its vascularization and its metabolism are damaged by the loss of testosterone. And this phenomenon leads to hearing problem and vision problems. Last but not least, nervous breakdown. Next slide, please. It is proved in men that aggression and hostility are correlated by the production of testosterone. And when you have a testosterone ranging around 600 and more, you have reaction. Behind, with old people, means after 45. The mean results are 404. And those studies prove that when you are around 400 nanograms for over 100 milliliters of plasma, you have not the same reaction as young people. Next slide, please. You see also that you have a correlation between aggressive behavior and social dominance in men. This study was made in prison, and prisoners who were non-aggressive, making checks without provision, had a low level, medium level of testosterone. Socially dominant, it's bank failure and everything, you have more. And here, aggressive men, you find they're murderers and so on. Next slide, please. This has intrigued me because when I look to the National Center for Health Statistics, I discovered this. The number of deaths by accident in the United States in 1982, under 65 years, by accident. The difference between and women, you see, 54,000 deaths of by accident for the men and only 17,000 for women. But after 65, you see that the rate of death by accident is the same for women and men. So you can conclude from this that because men lose their androgens, they lose also their aggressivity. You see that here. Next slide, please. And then there are reports also over nervous breakdown, which prove that depressive men have low testosterone. This is very low. And non-depressive, it was made on another group which was non-depressive, consulting for impotency, and then when they are not depressive, you can find a good level of male hormone. So, the male climacteric is the whole of the physiological and psychopathological phenomena going with a natural cessation of the male activity. Testosterone is the key treatment for all those diseases. Its use constitutes a real means of prevention of sexual involution and of aging. With the replacement therapy of other leading hormones, the regressive man will be replaced by the progressive man. Next slide, please. Who will ignore andropause, aging, and senility. Next slide, please. And you see here the regressive man. This is a man of 55. And the progressive man is here 20, 40, 60, 80, 100, 120. Next slide, please. And this is the book which is published just now, this week, in France, Belgium, and Swiss, which is a popular book, and we hope we will translate it also in English with another title, because it means over this limit, this border, your ticket is always good. But it's good in French, but it means it not nothing in English. And now, to conclude, if you want to maintain a good musculature, don't forget to check your male hormones. Thank you.
Thank you, Georges. That was fantastic. Gentlemen, the message is plenty of monkey glands and no exercise. That was worth coming from England to hear. Well, it remains for me to thank you all very much for coming, for thanking Pat Puleo and the Barnes Foundation and Wally Simmons for putting it on, and most particularly to thank our speakers, Dr. Otis Miller, Thierry Hertog, Jacques Hertog, and Georges Debled, for giving us such a remarkable and fascinating insight into how things are going with androgens and hormones at the moment. Many thanks to you all.